Good
Good
morning.
morning. And good morning. How are you?
Good.
I love to hear that every time. Well, it's nice to see you again
You too, Carolyn.
after a hiatus of 4 days. And as is always, we have our questions.
All righty.
So let us commence. Okay, question number one comes in. Interesting. I am very curious to know what Dr. R has to say about my using an IUD. Would the progestins from the IUD and progesterone from HRT compete with each other? How would the progesterone receptors react? I do have an IUD and I am taking HRT progesterone.
Well, this is one of those instances where there's an individual question about an individual patient, and you'll have to mute. We got that crackle again. And because there's what this really calls for is an exchange of information. And it would just be impossible for me to advise this patient on a medical issue of this nature without acquiring a lot more information. Like, when was her last period? Is she truly in menopause? How essential is that IUD? Etc. In general, there comes a point where birth control protection is no longer needed. Gynecologists define this as no period for 1 year. Unless you can tell a healthcare provider that you haven't had a period for a year, that healthcare provider has to inform you that you still could get pregnant. And so this is some of the unknown information with this patient. Then there's the reasons why is she taking both the progestin that's in that IUD and the progesterone. And the answer is probably lies within the need for questions. It's like if she's augmenting with micronized progesterone compounded by identical, there's probably reasons why she's doing that, and the progestin is not carrying the day. I'm not a super fan of progestin, to say the least. If it was the only tool I had, I would celebrate it. But I've never prescribed a progestin in my life. That molecule is quite a variant from what natural bioidentical, that means the molecule is identical to what a woman's ovary puts out as progesterone. Progestins are quite different, but they serve functions and they're not a zero. But in menopause, we never think of giving a woman a progestin. We give her progesterone. And then what kind of competition exists between the progestin for the progesterone receptor site and any additional progesterone? Well, part of the answer to that has to lie in the clinical. And it comes down to, why is she added in the progesterone when she's already on a progestin? That progestin is strong enough to prevent ovulation. That's one of the reasons it's so powerful as birth control, for birth control. So it takes us down to this basic phenomena. If a woman is in midlife and she's getting symptoms and or her periods are getting irregular, she's got a job to do. It's a critical job. And it is to find a healthcare provider that really knows what they're doing about treating women in menopause. And of course, the world that I live in is with compounded bioidentical hormones. That's the job. it's not necessarily a simple job, because there's very, very few healthcare providers that have chosen to specialize in treating women in menopause with compounded bioidentical hormones. Those that are treating women usually have these broad-based practices, and the hormone part, the menopause part, is a small part of it, and they don't necessarily reach out to get the level of education. They're not getting the level of experience that's needed to combine with their education. Traditional medical specialties, which there isn't one at this time, they call for a very serious educational and mentoring program. There's not a gynecologist out there or an internist, et cetera, et cetera, et cetera, that hasn't done something like a 2 to 3 year residency. And during that residency, there's a lot of information that they acquire, and there's a lot of mentoring they acquire. Well, in menopause, we're dealing with hormones. These are the most powerful biochemicals that exist. And this whole field of treating women in menopause has been severely stunted because of false information that came out in 2002. Everyone shied away. Women and healthcare providers shied away from treatment for fear, incorrect fear. The opposite's actually true, but it was incorrect fear that exploded into the public media scene, that women were at increased risk for breast cancer, heart attack, and stroke. The opposite is actually what the science is. So I know I'm meandering out there in Meanderingville. Once again, Carolyn, although you've never caught me do that ever, if I remember correctly. I may not be remembering that exactly correctly. But the bottom line is, this woman needs to link up with someone to really individualize the individual moving parts. Like, where is she in midlife? Is she still having regular periods? Is she still having intercourse? Is there, so there's so many missing pieces of information that I can't possibly answer that question. And you do the best you can. If birth control is really important, then you focus in on the birth control. Would I have any concern of giving a woman who's having progestin, additional progesterone, micronized progesterone? Not if there were indications, I wouldn't be concerned. Progesterone's got so much safety to it. For example, if this woman started taking additional compounded progesterone because she was having symptoms of progesterone deficiency, and she took the progesterone and it made a big difference, some of the most common symptoms of insufficient progesterone are mood alterations, as in super uncomfortable anxiety and even depression, can go all the way there. Or sleep disturbance. Now, estrogen plays into sleep disturbance, progesterone plays into sleep disturbance, but progesterone can play a major role. And there's many women who get to sleep whereas they weren't sleeping by taking oral progesterone at night, or even topical progesterone. So these are the kind of factors that need to be looked at. If, for example, this woman was not, she had this IUD with progestins in it. How long has it been in there, by the way? How much progestin is left? She got an IUD with progestin, and she got mood issues and sleep disturbances, and she wound up getting prescribed micronized compounded bioidentical progesterone, and she got those symptoms alleviated. I wouldn't hesitate to carry on with the program, and then one day those periods are going to stop, and one day she's going to be 1 year without bleeding. Then she can remove the IUD and go on to a full hormone program. I mean, she may also need estrogen even now, but there's so much missing information there. So I know that that's not answering the question in a way that you would probably really like, but it calls forth what always has to happen, that women are individuals. They all have their individual situation. So are men, for that matter. Men in andropause, they always got to do what we always do, which is get the details of the individual and tailor a program based on the individual details. It's so imperative. So it turns
Okay.
it turns to her job, which is finding someone who really knows what they're doing. If you want a roadmap of what's going to need to take place at the foundation with which is treating women in menopause with compounded bioidentical hormones, download the book that you've made available, Happy Healthy Hormones. You'll get a roadmap of what you need. And for me, the essential moving parts are compounded bioidentical hormone treatment, individualized, 24-hour urine hormone testing at the 3 to 5 month time when a woman's dialed in clinically, her dosages. And for me, oh my God, I wouldn't dream of prescribing anything other than topical estrogen and testosterone in our compounded bioidentical oils, our compounded organic oils. So those are some key moving parts there. There's a heck of a lot more. But if you want to get the best of the best, you find yourself a provider. You make sure that they're doing the 24-hour urine hormone testing, or no one's going to know what's going on in your body to the level of detail that we really need once you're on the hormones, and that you're getting prescribed compounded bioidentical hormones. The topicals are dispensed in our certified organic oils base. You'll read all about it in Happy Healthy Hormones.
You will read all about it in Happy Healthy Hormones, and if you read it twice or three times, then you're going to actually start to really, really, really get into it and understand it. It's a really well written book, and it gives so much information. There's a lot to know, as you've always said, lots of moving parts. And I appreciate the answer to that question. I do see these other questions, and I say good morning. I want to get to a couple of these questions first, if you ladies would be patient enough, and I thank you. Dr. R, let me ask you this, please. This is an interesting question to me. Is there a video on SHBG, meaning sex hormone binding globulin? I think that this is my problem. My total testosterone last check was 17 and my free testosterone was 26, but my estrogen, my estradiol was 58. It seems the more estradiol I use, the lower my estradiol is going in numbers, and the higher my free T is going. So the more estradiol I use, the less estradiol I feel. So what is the optimal number for sex hormone binding globulin that Dr. R suggests?
The topic is a great one, and it doesn't come into play commonly, but it does come into play frequently enough. And I want to give you the background. The optimal number depends on the lab. For example, there's different optimal ranges. They're not optimal ranges, they're reference ranges. That's a whole other story. Quest, depending on which particular technology they're using, they have two different reference ranges, and they're quite different. And LabCorp has a single reference range. And you at least want to have that sex hormone binding globulin within the reference range of whatever lab you're using. And sex hormone binding globulin is obtained by a blood draw. We always like women to go in fasting, water only, no toothpaste, no nothing, from the preceding midnight, though it's not that critical with sex hormone binding globulin. But you have to look at it in comparison to the reference range of the lab that's doing the test, and they're very different. But it's not hard. I mean, you could think in terms, if you're looking at a reference range from, let's say, 60 to 125, And where do you want to see your sex hormone binding globulin? Probably somewhere in the middle. So let's say 90. But even if it was up at 124, it's showing that there's some challenge there, but it would be acceptable. As you start getting sex hormone binding globulins that exceed the upper limit of the reference range, you are going to have a clinical problem or you're not. What kind of response is that? Well, there's some women, sex hormone binding globulin blood test is mandatory in the menopause method. We wait to the first visit and see what the woman shows up with as far as blood tests that are recent and that she has. And if we're looking at her blood test reports and we don't see a sex hormone binding globulin, we write a requisition for her to go to the lab to get a sex hormone binding globulin. It's a pretty common thing. That's how important we consider it to be. We always get it. And we always want that baseline. Now, there's some women that when we're looking at their baseline sex hormone binding globulin, that thing is elevated. And I'm talking about women that they haven't been treated for menopause. How in the world did that thing get elevated? The most common reason is they were young and they took the birth control pill for a certain amount of time. And here you are, a young woman with your maximum amount of hormones you're ever going to produce in your whole life. And you take the birth control pill and you're getting extra estradiol. You're getting extra estrogen in there. So now I want to talk a little bit about what's the consequence of that and what's sex hormone binding globulin about in the first place. And again, in happy, healthy hormones,
You're frozen, Dr. R.
can you hear me, Carolyn?
I can hear you, yeah, and I can see you smiling, but you're not moving. It's okay. I can't hear you though. So
How are we doing?
now I can hear you.
Okay. So I'm going to pick up and I want to describe what sex hormone binding globulin is. So you'll understand what you're looking at here. We have everything that matters that needs to be circulated to the whole body is circulated in the bloodstream. And most of the blood, or a certain high percentage of it, is water type stuff. Actually, there's minerals in it, so it's like seawater. Well, there's other things in the blood too. There's cells in the blood, and there's proteins in the blood. And they're circulated to every cell, tissue, and organ.
Back to frozen.
Can you hear me when I'm frozen?
No, I can hear you now. It's okay. Kind of going in and out.
I think I'm going to do a restart. I'm going to do a restart, Carolyn.
I hear you. So, okay, got it. Oh, ladies, in the event we do the restart, please put your questions back up again. I know I'm live. I don't know if Dr. R is going to come right back up here. I know that I'm live. So give me a second because I'm not sure what to do here. Hang on.